Welcome back to another episode of 22 at the Lips. I am still your podcast host, Alexis. I have not been voted off the island yet, but we'll see what happens. If you are new, if you have somehow stumbled upon this journey of a podcast, welcome. Thanks for being here. It really means a lot. Anyways, this is the podcast host from EMS providers such as myself and the guests I have on two other EMS providers, whether you work in the healthcare system in a hospital setting or on the ambulance like most of us, or you're a helicopter flight medic. Wow, congratulations. Or you are just the random everyday average bystander who is here for whatever reason. We appreciate it. Thanks for being here. So usually I have a lot of people on the podcast to talk about either their experience in this job, whether they work on the ambulance, if they have a different avenue that this career field has brought them into. And today is no exception to that rule. He's not quite a doctor, but basically, Mr. PA man, Matt Holden. We met through the Master Medics team. So far, seems like a really cool guy. And we'll see if he still upholds to that. But Matt, if you want to tell the people who you are, what you stand for, how did you get here? What do you even do? The floor is yours.
You know, that's an excellent question because I don't even know what I do at this point. So my name is Matt Holden. I'm the co-founder of Scope Education. I like teaching and medical stuff. I was a paramedic actively for nearly 6 years. It's been dormant for about 2 years because I'm currently in PA school, hopefully going to be graduating in 3 months, but, you know, not counting down or anything. The light at the end of the tunnel is not a train. I figured that out now, so I'm excited. And yeah, I'm excited to be here. Thank you so much for allowing me to come here.
Absolutely. Usually I try to have people on that can benefit anybody else that listens. If they're in EMS, whatever the case may be. Today is very selfish. It is for myself. PA school is, if you've talked to me for any length of time, it is my next step. It is what I'm actively pursuing to do. So you guys just buckle up, you know, hang on for the ride, whatever. I'm glad you're here, but this is for me. So Matt, you said you've been in EMS for 6 years.
Yes.
A couple of little questions I did not prepare you for.
Okay.
First question. We go on a myriad of so many types of calls, whether they are psychiatric or geriatric in nature, cardiac, I don't know, trauma, refusals, falls, lift assist, rescue. I don't know. We have so many types of calls that we go on. If you had to narrow down what type of call was the one that on the way, you're like, man, I hope we get to do something. I'm excited for this one for XYZ, whatever the case may be. What was it for you?
Simple. I know you're a big respiratory person, you know, but I like the thing that goes lub dub. Any kind of cardiac call, you know, your syncope, your chest pain, you know, something like that. God, I tell you, I got so excited. I'm like, oh, could it be an OMI? Could it be like Brugada syndrome? Oh my gosh, maybe long QT syndrome. And I got so excited. I'm like, oh, I could pace. I could do all that kind of fun stuff, get some pressors. Gosh, I tell you, nothing gets me more excited than seeing a good old cardiac call sometimes.
I respect it. I like the cardiac. It's not that it scares me, but it's always in my experience, it's the calls that, well, my chest has been hurting for XYZ hours, whatever. You get the 12 lead and it's sinus rhythm. And you tell the patient, well, it doesn't look like anything scary is going on from what we can see. Oh, well, I don't want to go. Okay, but there's still things that needs to get checked out. Oh, I don't want to go. If you can't see it, I don't want to go. Why don't you please just get on the stretcher so that way you don't die and it's my fault?
I'm not panicking the next month or two waiting for that phone call being like, hey, do you remember this patient?
My biggest fear, I wish I was joking, almost an everyday basis, is being somewhere and seeing the police walking up to me. Are you Alexis Hardwick? You're under arrest for the murder of so-and-so. I'm not even going to remember who it was. And I'll be like, oh no, what did I do this time?
No.
It's not going to happen. Fingers crossed. It's not going to happen, but
knock on wood.
The chances are never zero. So my next question. Given the choice between pie or cake, which one are you going for?
So I really love me some cake batter. I prefer cake batter over normal baked cake. And so this is gonna be a little weird. It's gonna, offend probably half the population. And I'm willing to take that blow, okay? But I will die on this hill. Cake batter is better than cake. Alrighty. When I was growing up, my parents, we wouldn't even bake a cake. We would get the whole thing, and then each kid got like 3 or 4 big scoops of batter. We felt nauseous and sick afterwards,
I'm
but it
sure.
was phenomenal. But at the same time, nothing beats like a good cherry pie or a banana pie or something like that. My wife doesn't let me have cake batter, so I've had more pie recently, so I'm going to go with pie.
Is it like she has the bowl and like you're like going towards and she's like, no, 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 not again. You've had too much already. And it's like
Yeah, like I'm
over her
some
mouth.
2-year-old. She's like, no. She's like, this just, you feel nauseous and sick after. Like, why are you doing this to yourself? But she just thinks it's absolutely disgusting. And she's like, absolutely not. So I don't even get the real opportunity. I tried it like once or twice and that was a hard no. That was a really tough pill to swallow for me. Big red flag.
No, I saw this meme one time and it was like, it said something to the extent of like, being an adult means that nobody can tell you that you can't have 37 tater tots for breakfast. And I was like, oh, yeah, you're right. And then the next slide was like, but being an adult means finding out the hard way. You shouldn't have 37 tater tots for breakfast. And that's just the big definition of what, for me, growing up has been. It's not even like, oh, I can do my own laundry. It's like, oh, I shouldn't be eating, a fajita leftovers at 3:00 in the morning because I feel terrible the next day. I am not who I used to be.
Getting old.
Okay. All right. So let's backtrack a little bit in your so far extensive career already. Oh my gosh, what more can you do? But going back a little bit of rewind. What was the choice of going into EMS from the get-go? Because like everybody has, I mean, there are general categories that are like the same, but everyone has their own unique, like, this is why I joined EMS. This is why I became a paramedic story. So like, what's yours?
So this is going to be a little embarrassing. So get ready. So when I wanted to go to school, I instantly wanted to do, the go from, get my bachelor degree and then apply and go to PA school. And I was going to go just straight through, maybe take 6 months at the end and apply. My first year, I was really immature and unable to handle being alone in a different city away from my parents. And so I prioritized fun. Now, fun is great for memories. It's not great for your GPA. So my very first year, I think I racked up 2 C's and 2 D's. Like, I think I was put on academic probation. Yeah, so if you don't think that you can get into PA school, I'm letting you know. If a person with my IQ can get in, you can get in. Alrighty. So I realized at that moment, oh God, man, I need to shape up. I am not ready to just power through 4 years of school and jack up my life. So I decided to, when I went back to my parents' house, I went and did EMT school just because I knew I wanted to do medicine. And I'm like, oh, maybe I can work as an EMT. During my ride-alongs, as we all do ride-alongs in EMT and paramedic school, I got to see the paramedics do some really cool things. And I'm like, I want to do those cool things. I saw the medic. I didn't even know what a 12 lead was. And this dude like prints off a piece of paper with some bunch of squiggles on it and is like, oh, well, this is LVH. And I'm like, what did you just say? What is that sorcery? So I wanted to learn that. I thought that was really cool. So after that moment, I elected to drop out of my university and then go to a tech school. And then I got an associate's degree in paramedicine or emergency medical technologies, technically. And I fell in love with the whole emergency medicine. It just hooked me from the beginning, and I absolutely loved it.
So do you feel like, I mean, not the answer is yes, but like, not just that did being a paramedic have a factor into becoming a PA, as you said, but like, what was the holdup of like, I want to do PA. Let me do paramedic for a little bit. Was there a moment when you were like, maybe I could see myself doing this, or was it always like PA from the get go?
So my mother is a PA, and she's been a PA since, ever since I could remember at whatever normal age you're supposed to remember things at. Is that 3, 4, 5 years old? I don't know. Regardless, ever since I can remember, my mom's been a PA. So she was also born with a rare congenital heart defect called Al-Kappa, or anomalous left coronary artery from the pulmonary artery. She was supposed to die like 7 times before she reached the age of 18 and all that kind of stuff. She's still powering through. I mean, she's very, very
Wow.
strong. A very strong woman, now, but she has a very fun life. But as I was growing up, I was able to see what a group of PAs and physicians were able to do and how it really benefited her life. And at the same time, it instilled in me that I really wanted to go to PA school. I didn't want to be like a doctor and, start making money when I was 45 or whatever. It just, I mean, it just seemed like so much, and I didn't like the work-life balance, and so I knew instantly, since I was young, and before I wanted to do marine biology. Then I realized I would be looking at algae and plankton for the rest of my life, making not a lot of money, and that made me sad. So then I was like, I got to definitely, by high school, I'm doing PA, absolutely. But I'm not gonna. I've honestly always wanted to do it. I love the idea of being a PA, and that's why I'm here.
Paycheck doesn't hurt either. No. So answer the, I feel like the big question. It's the one that, like, when I was trying to figure out what my next step was, whenever I decided like RT, just, it's not going to be for me. Don't know what I'm going to do. Stumbled upon PA and I was like, I've heard of these before. I wonder what this does. Sorry. What is a PA? What does the school entail? How is it different from like what I feel like a lot of people confuse of like a nurse practitioner? Where do PAs fit into the realm of the healthcare system?
So, excellent question. You definitely need
Thanks.
to know this if you are applying to PA school. And so, my answer that I gave during my interview is that a PA is a mid-level provider. So you have your physicians up here, your mid-levels here, nurses, techs, all that kind of stuff. But the PAs is what is the junction between nurse and physician. You're able to order x-rays, CTs, prescribe medication, do a lot of, paramedic kind of like skills with some additional ones. I'm a very simplistic man. I barely have 2 brain cells that synapse at times. And I like to think of things in really just simple kind of ways. And I'm going to offend someone I know who thinks that, I'm being dead serious right now, but in a very simplistic take. I mean, if you think about it, I mean, a PA is just a super paramedic. You just have more tools. You can, instead of being like, oh man, what's going on with this abdominal pain, I can run labs, I can get a CT scan. Everyone gets a CT scan in the emergency room, so that's kind of what it is that bridge between a nurse and then a physician. And most people, I feel like, prefer actually PAs. NPs have very similar kind of training, obviously, but I didn't want to go through the whole nursing pathway. Just did not interest me at all. And I got confused a little bit. Like I said, low IQ man over here. I had some difficulties trying to determine, like, oh, you can only specialize in like pediatrics or adult med, and you can't cross over and stuff like that, or you got to do family medicine and you can only get certain, I don't know, it was just way too complicated for my simplistic brain. So I'm like, all right, well, I wanted to do PA, and it's further cemented that I wanted to do PA. And yeah.
Someone said it perfectly one time. It was one of the many podcasts I listened to. They said something to the extent of, what was it? I should have wrote it down, because if I didn't write it down, it's gone forever. Basically, like something to the extent of like, a doctor wouldn't be able to go into a call and honestly excel with what little they're provided, like a paramedic can. And they were explaining how, like, a doctor, you pick them up out of the ER, you put them in the middle of this house with only a cardiac monitor and your own physical assessment.
Yep.
And they'll probably get to it because they have a lot more education and money than we have. But like, without all of the extra special tools and kits along the way. Versus we're doing this and like at 3 a.m. when we just woke up after getting slammed the whole night and it's dark and the TV's on and somebody's watching it because they're always just sitting in the corner watching the TV with full volume. Anyways, so like that is the thing that I guess was appealing about PA is kind of like I don't lose the autonomy to make decisions, but maybe this is just a cop out. I don't have my signature as like the end all be all signature on everything. And I like that. So
Yeah.
like I'm not going to medical school. I don't want to be a doctor. Mad respect to doctors. Couldn't be me. And also like, man, I'm starting too late. Like I'll be 60 by the time I can actually practice.
Yep.
And my back's gonna be out from this job. So
And I think you put that perfectly. I mean, and also PAs can, was it horizontal or lateral mobility is I think the buzzword everyone uses or something like that. I mean,
Mhm.
I like all aspects of medicine. Yeah, obviously, cardiology number one, obviously, but I like pediatric side of cardiology. The congenital heart defects. I like basic cardiology. I like critical care, I like emergency medicine. And if I'm like, okay, well, I'm kind of burnt out with doing this, I can go to the next one. A physician, unfortunately, is really stuck in that one thing unless they wanted to go through residency, which could, take between 3 to 8 years, depending on your specialty, and then probably a fellowship. And some people have done that, but I didn't like the idea of being just tied down to just one single aspect of medicine when medicine is just so broad and there's so much to learn with it.
No, 100%. And I feel like by having the paramedic backbone like you had going into PA school, in my mind, it makes sense, but like, do you feel like that kind of helped you? I don't want to put it the way it sounds of like put you a step ahead of everybody else, but do you feel like it puts you a step ahead of, whereas like you have some people going in that have never done medicine for like a day in their life?
Yes. So I think it did bring in a big step up for me. And the reason why is because I try to think of medical education and learning as building a house. If you don't have a very solid foundation and you try to build a mansion or a wealth of knowledge on top of it and it's really crappy, it's going to break and you're not going to be able to get on top of it. But if you have a really solid foundation, and that's what I'm glad with, I'm glad I failed out of school my first semester and did paramedicine and was able to practice and stuff like that. I'm so glad I made that decision. I wouldn't change it because of, how much of an advantage it kind of gave me in school. I mean, school is still, incredibly hard. It's not like a cakewalk. And there's a lot of stuff that obviously you don't learn and in paramedic school, or even when you're searching the FOMED pages and, EM crit and stuff like that, and you're reading and nerding out, like you don't learn about a lot of these different things that you're learning in PA school. But I would absolutely say it did give me a big boost in confidence and a better foundation in comparison to some people who didn't. Most of the people, we have a couple of paramedics in our school, and all of them are doing fairly well. Even EMTs and stuff like that. We have a lot of EMS people, and they're doing very well in school. The next class that just got hired, they actually preferred to get more EMTs and paramedics as well because of the track record.
Hmm.
Yeah, because they know you come in with that good foundation. You want to build that mansion of knowledge.
Very interesting and very comforting. Um, if you had to think about like, okay, let's also backtrack a little bit. What does PA school entail? Because I know what I've been told is, okay, you wanna join as soon as you get accepted into PA school. Be prepared to not work for a year, and then the next part of your year is just your clinicals and field experience. So like, how much of that range true? How much of that is solid? And like, what do you do? What is a PA school? What does this mean?
So, for people who do not know, PA school is a master's degree. So you get a bachelor's degree, then you get a master's degree. And in PA school, obviously in paramedicine, when you get your paramedic, most of us had to take anatomy and physiology and stuff like that. You do the same thing in PA school, and you're thinking, oh, well, sweet, I already know. No, there's so many parts of the body that you didn't know existed. I still don't even know they exist. It's just foreign to me. But yeah, you do a repeat. Usually your first, and every school is a little different. They have a same kind of general curriculum. And you would get your basics out of the way, your laboratory medicine, learning about your labs. So if you want to do that, learn your labs before you get into school. Build up that foundation. But you're going to do a lot of anatomy, physiology, patho, just your generic kind of stuff. And you get into your clinical assessment classes, or CAM classes. I forgot exactly what they're called, but it's CAM. And you start learning how to assess patients, how to ask questions, and it becomes a very structured kind of thing. And you learn how to take a history and how to ask questions, how to get your differentials. Patient has chest pain, you're learning as a paramedic. I'm like, all right, well, I put everything into a bucket and I'm going to ask a couple of questions and just pull out my differentials. I'm like, this is wrong, this is wrong, this is wrong. It's probably not this. Oh, probably this. And then, kind of sort through it like that. As a PA, you learn to go just about 2 or 3 steps more of deeper questioning, just because the more pathologies you learn and various syndromes that you learn about, you're like, oh, well, they have elevation in V1, V2, and I'm thinking paramedic, I'm thinking STEMI. Okay, easy layup right there, right? But then you start got to think about, Brugada syndrome, your coronary artery dissections or something like that, or aneurysms that can also cause that. So it adds a different level of learning. And so you do that in a lot of your classes, and you just slowly build. In each one, you got to take a final exam, and it's probably the most stressful part of your life. It's just, it's very similar to how I felt in paramedic school. Drinking water out of a fire hose kind of thing. You're kind of just bracing for impact every day. But it's a lot of fun. I mean, the amount of stuff that you learn is incredible, and I loved every bit of it. So you do your kind of basic one of those, and then after that, you just take your final exams. You do start doing something that are standardized exams, such as PAC-RAT, and it's kind of like a summative kind of testing of all the knowledge you kind of learn already. You take that right before you go into your clinical year, and then after that, you do your clinicals. You do like your ER, your OBGYN, your internal medicine, your pediatrics, family medicine, all that kind of stuff. And during those rotations, you take an end of rotation exam. And that is purely specific to that exact rotation you went on. And I thought I did emergency medicine for, 6 years. I'm like, oh, okay, that's easy, right? Wrong. That was really hard, actually. I passed, but I mean, God, I cut that close, But there's a lot. I think I even sent you some of these.
I have all of them.
Blueprint. Yeah, you can nerd out. It's a lot of fun. So you can look up like EOR study guides on Google, and you can get some free access ones, and you can kind of just look and nerd out as much as you want. But after that, you take your endocurriculum exam, which is what I just took, and then pass. And then, next step is PANCE, and that's your credentialing and making sure you got a certified after your name, or C.
I started looking through, and I know it's like, it was the big study guides of all the study guides of all the things ever. But I was like, I feel like I'm not going to do terrible. I feel like, a general grasp. Let me just take a little gander real quick. And I opened one of the files, and after about 5 minutes, I closed it. I started sobbing. I said, I'm never going to do this. I'm never going to make it. It's the end. I'm not even going to start this progress and journey because I'm never going to get there. So it does not look like a walk in the park, and it's not meant to be, because if it was, everybody would do it.
Yes. And I will say that for the most part, whenever you get into it, when you apply and you get that interview and you get that rush of euphoria and you're like, oh God, if you get an interview, they know that you're smart enough to succeed in the class. So if you're getting an interview, that means they know you can make it. Everyone, you come in and out, as a paramedic, they want to know that you're coachable and teachable. I can't be like, oh, this is how I did it for 6 years. I know so much better than you. Like, you can't come in with that kind of attitude. Mm-hmm. You learn all these different kind of things, but I mean, as long as you get the interview, they prepare you, and you do a lot of studying on your own. Sometimes you kind of just wing it. Like my CT surgery, I did like 60-hour weeks. I was so exhausted. I had to buy new shoes after the second day. I had to change shoes from On Clouds to Hoka's just because my feet hurt so much from standing in that OR and doing rounds in the CVICU. On the first week, I believe we had a dissection come in. Aortic dissection got flown in for an emergency surgery. So I was already up for 10 to 12 hours at that point, and they came in at night. So I got home, and then I got a text saying, "Hey, optional, but you can come in." So I'm like,
I'm
"Well,
not
I mean,
going to
optional.
pass that up.
Kind of see this." And they're like, "All right, we're gonna go get Chick-fil-A after this." And I'm like, "It's 8 o'clock at night. What do you mean?" And I'm like, "Oh, they mean the morning."
The morning. Oh, God.
And that was a long 10, 11, 12-hour surgery. And all it was, if you think about a CT surgery, is sewing circles together. Simplistic way of putting it, but yes, sewing circles together.
There's not a lot from this job that phases me as far as like bodily fluids, smells, this, that, and the other. There are two very specific things, one of which is not part of our field specifically. The first part, can't talk about it a lot. It's not teeth in the mouth hole when they are broken. It is when it's outside.
That gets me a little nauseous, I'm not gonna lie.
I can't. The other one is I found out through OR rotations. It wasn't even while I was in P school. It was while I was just doing this extracurricular, like the company that I was with, they were like, hey, if you want to drive to the big hospital about an hour and a half away, you can go do some intubation clinicals and like just rotations, this, that, and the other. So I was like, why would I pass this up? Absolutely. Did the intubation for the patient going in for the bariatric surgery. Love that. Little gastric sleeve. Cool. Okay. Nice. I never connected the dots on like what the less invasive surgery is, the with the robot arms and all that stuff.
Mm-hmm.
They start inflating, swimming, and I'm looking around like, oh God, I don't think this is right. And they stick all the probes in, and I'm like, oh, that does something weird to me. I don't like that. They're literally the surgeon is talking about so and so is about to have a baby and how exciting that is, and like the picnic that him and his family are going on that Saturday, just carrying on. And I'm like, I feel my knees getting a little weak. I'm like, oh, all of a sudden they do the snippies. They get their little, I don't know, whatever tool, grab it and start pulling through this woman's belly button. Thankfully, my like regular shift partner was with me because she's like, oh no, we're not doing that. She like grabs my elbow as I'm like, oh God, I can't do this. So I know that one's not going to be for me. Haha.
But they're super cool. I mean, I kind of had the same kind of experience like when my first day of CT surgery, like, I mean, we did it's open heart surgery, a lot of and people like when we hear patients say, "Oh, I had a cabbage done." I'm like, "Oh, okay, it's so common." I'm letting you know that is brutal. Like I mean, I got to do a sternotomy one time. It was nice. You take a big old saw and just go down someone's sternum. You spread it apart. You go through all the pericardium and all all that kind of stuff, and you expose the heart. You create like a cradle, and you kind of lift the heart up with a sack around it, and then at the same time, then you just find the blockages. And the whole time we're listening to like old 70s, 80s rock, and we're having some fun, laughing, and all this stuff. And here I am having a panic attack because I'm scrubbed in. I got my all sterile and stuff like that, and I'm like, I was told if it's blue, it's not for you. If it's blue, it's not for you. And they drape patients in blue and showing it's very sterile. Like you cannot break sterility at all, or you'll get like stuff thrown at you. Luckily, I had some really nice surgeons, and they didn't yell at me. I probably deserved to get yelled at a couple times. I didn't break sterile field, but I was so terrified. But in the cabbage procedures, they literally like go in the coronary arteries, and they do vein grafting. A lot of PAs will do that, and they'll take like the great saphenous vein or something like that, or a radial artery, and they'll just insert this little camera thing, and they'll go in, they'll just dissect it away from the fascia and the muscle, and then at the same time they'll just go in there, they'll tie it off, and then they'll snip, pull it out, and then they'll kind of get rid of all the bifurcations, tie off those, and they'll just tie two circles together, that one end to the other end, and then that's your cabbage. And then at the same time they go and they put these wires in and wire your sternum back together. And I'm like, it's not an easy process, but and it takes like 4, 5, 6 hours depending on the surgeon. But I'm like, we hear cabbages all the time as an EMS, and I'm like, I didn't realize it was It's a lot of work. The patient goes through a lot.
Jeez. I just, oh, surgery, man, not my thing.
No.
So besides possibly like cabbage procedures, what is something that you've seen either in PA school or something that you've learned about that feasibly you wish could be put into EMS?
So that's a very good question. I think what I wish I learned a little bit more is the flow and the amount of depth that you ask your questions when you're doing like your history and physical, because that's like the most important aspect of treating your patients, trying to figure out what exactly is going on. And like learning, I'm more than willing to talk about the whole thing, but usually have your whole list. And I know, unfortunately, it comes to like, I know there's this big, debate of whether paramedics need to have a bachelor degree and all that kind of stuff. And I think there's no such thing as too much knowledge. I think learning as much as you can as possible is a fantastic thing. So I think learning those extra couple questions to ask, it could really benefit at least me when I was going through it. Like kind of, I brought up that same kind of thing with the elevation V1 through V2 is just a STEMI, and then you got to start remember a little brugada and your coronary artery dissections and stuff. And having a bit of a bigger differential list is really important, especially if the patient wants to go to a non cath lab hospital, right? And in some places, like I was kind of blessed that most of my transports were less than an hour. I was really kind of lucky. I didn't have to panic too much in the back of the ambulance by myself. But there's some places where you're kind of really alone and you got to make that critical
Yep.
decision. Yeah, it's like you got to make that decision. I'm like, all right, do I take you to this hospital you want to go to? Do I got to really convince you to go to this other one? And you got to make those decisions. And I think if you're able to ask those extra couple questions and stuff like that, that could really make a difference for your patients and knowing a little bit. And I know I didn't learn this in PA school, but it's kind of like the occlusion myocardial infarctions or OMI, like your STEMI equivalent, your hyperacute T waves and lead 3, and you look for a flip T wave and AVL. It doesn't show any elevation, doesn't meet your STEMI criteria. Patients having chest pain looking like a STEMI, looking like a heart attack, a walking, talking heart attack. They're pale, cool, diaphoretic, and crushing chest pain, but they didn't want to go to a cath lab. And I'm like, well, I see a hyperacute T wave in lead 3. AVL has a flip T wave. So I need to convince you to not go to that hospital and go to the cath lab, go downtown and get that done. And unfortunately, like, I have had a couple of these patients where you kind of send the EKGs in and the physicians and cardiology tells you to kick rocks and says, nope, no STEMI, I don't care about that. And then, unfortunately, the patient kind of just sits there and infarcts for God knows how long until the troponin comes back at 77,000. And they're like, oh, shit.
When did this happen?
Oh, gosh.
Which patient is this? It's
There's
yours.
that's the power of serial 12 leads and stuff, but I know that we're trying to get to more. There's a debate of going to OMI versus NOMI for opposed to STEMI versus NSTEMI to include the STEMI equivalents, but that's a different. That was a little rant right there, but yeah, just knowing a little bit more and asking those extra questions and just trying to better yourself and learn. The stereotypical learn something new every day. Try to learn if you got nothing like me going on for the next 2 weeks. I mean, I'm going to try to learn 10 things a day. And there's that way it can even out to one a day. In the grand scheme.
Give me an example of like when you say the going further in your history taking and your assessment and stuff like that. What is an example? Like, what is something that you learned it and you feel like you'll never like it's never going to go away and it can be used for every single patient from now on, besides ordering a CT?
So you can get into I can think of some of the coronary aortic dissections and stuff like that, and kind of just trying to figure out your typical one is your crushing chest pain and the radiates to the back and all that kind of stuff. It's your typical presentation, and if you take a blood pressure on one side, it's lower than the other side, and those will only occur in a certain amount of patients, but in patients that have some kind of chest pain, I always ask, where does it kind of migrate to? Your typical kind of questions. And then I ask, like, do you have any visual issues now? Are you having blurry vision? Because it could go up your carotid arteries. It can cause you to have dissection of the carotids or down into the coronary arteries as well. And so I'll try to ask some neuro questions and add a little bit more into it. If you're having patients with your ST elevation V1 through V2, would like be like, oh, do you have a family history of possible like early death in your family? Do you have palpitations at night? Do you feel like you wake up gasping in the middle of the night? Stuff like that. Like, or have you had a fever recently? Like a Brugada sign can be unmasked with a fever and stuff like that. So it was like, are you feverish? Are you having that kind of symptoms? And just kind of go down, just, I'm not asking crazy questions like a someone who's really intelligent, but I can break down, I can go at least 2 or 3 levels deeper, and that's all it is. And you can kind of figure out, is it going to at the end of the day change your general scheme of where you're going to go? Sometimes it can. Sometimes if I'm like, alrighty, well, it sounds like a aortic dissection going up the carotids or vertebral arteries or blah 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 blah, I think they need to go to, this is more appropriate hospital, I need to go there. Or it's like, okay, well, they're already having a aortic dissection, so it doesn't really matter. Just take the patient to that, level 1 trauma center, that big hospital that can deal with that.
I think it's so cool having like that pre-hospital background that you got now. So that way, like, I mean, this could just be me going in, dropping off a patient, and then the doctor, more than typically the nurse, is like asking questions. And I always get to a point where I'm just listening and I'm like, why are you even asking that? That has nothing to do with what's going on. I guess you're just going through and like crossing everything that doesn't. I never thought to ask, like, do you have vision problems? Oh, the coronary artery. I've never thought of that. So that makes more sense when questions are being asked. And I'm like, they're not having a stroke. Why are you asking that?
Duh. Yeah. Or like even abdominal pain, like, when we press on the tummy 4 times and stuff like that, but like, you can start actually oscillating and trying to listen, are they higher pitched sounds? Like, could there be a bowel obstruction? You're doing your tympanic press, your percussions and stuff like that, and trying to see like, oh, is there like a consolidation here in the lungs, or, in the right lower quadrant, or, you learn a couple more signs and specialty tests as well with an assessment, which is also incredibly important for, your patients. Obviously the questions are important, but then the physical exam findings you do is also really important as well. And that can really narrow down your kind of, things. So I had a patient that had right lower quadrant pain, started in the belly button, rated to the right lower quadrant. I'm like, okay, well, seems like a layup kind of, appendicitis. And then I just like, and part of the general kind of abdominal pain, assessment is, you get them up and you do CVAT tenderness, you smack them in the back, right in the kidneys. And the patient's like, oh, and I'm like, oh, have you had any, burning sensation when you're peeing, or, something like that, or any blood in your urine? And she's like, yeah, well, I actually kind of have. And I'm like, oh, okay. Well, we do see, obviously, ER, we always do CTs on everyone. We CT'd them and didn't have appendicitis or anything like that, or a very low suspicion of appendicitis is, I think, the legal way of saying it. But yeah, the patient didn't have appendicitis. I thought appendicitis, and you just smacked her back a couple times and you're like, oh, okay, it's not.
I think it also gives way to like the idea that I feel like it's hammered with us, but it's a forgotten skill. But just like the same idea of, it is so important to get a good physical assessment. And I'm not going to act like I get a great one every single time. There have been calls like last night at 3:00 in the morning when I'm tired. I walk away and I'm like, I know I listen to lung sounds. I don't remember a single one of them. I know they were bad. That's Mimo got her albuterol and solumetrol. My job is done.
Yeah.
I was very tired. Everyone,
I think we're all guilty of that. At the end of the day, like I can't be over here, all pompous and like, I've never done that. Like, obviously, like there's days where you're like getting your butt kicked and you're just, you try to slack. And sometimes I try to think of being like, well, if I slack on this, like, like what could I have missed? And
today I would just be slacking. Today I showed up. I showed up. I've got my ABCs covered. They're not dead. I have done the best I can.
Blood going round and round, air go in and out. When I dropped them off at the hospital, I did good. That's how I had the same kind of mentality too. It's like, I don't know what's going on, man. You got some tummy pain, but I my ABCs, airway breathing, can you walk to my ambulance, was done. So
Dude, that was the biggest, like, I don't know, biggest eye-opening experience was going in paramedic school and clinicals, all of this stuff. You have to know a definitive diagnosis for every single call. And in your scenarios, they're always like, oh, yes, I also have pain that radiates to this spot. It's like, oh, wow, congratulations. People do not fit the National Registry scenario molds. So it was such a disorienting idea that, like, I would leave a call and I'd be talking to a partner and they'd be like, well, what do you think is going on? And I'd look and be like, that's a great question. I can tell you what wasn't. A cardiac arrest wasn't what was going on. Yep.
Yeah. No. I completely agree. Yeah.
It wasn't going on yet.
There's a lot of mystery, and at the end of the day, a good old scan's going to figure out what's going on. For most patients, that's until you get imaging, like, or POCUS. POCUS is really good, as well as I know some agencies do carry that. My system, back when I was doing it, back in my time, we just got like Sapphire pumps right when I kind of was like on my way out there talking about POCUS, but they didn't really, they didn't get into it in the training involved. They're like pushed it back for a couple more years, I believe. But there's a lot of really good agencies that POCUS is really great to be used, especially your abdominal things, looking for gallstones or, appendicitis. You can kind of see some stuff there. And, anytime I was doing my ER rotation, everyone got ultrasound. The PA I was with loved ultrasounds. We do like midlines or PICC lines or whatever. And we, when we went to the ICUs to put them in, every procedure was done with an ultrasound guidance. Every patient got ultrasound. It was fantastic.
If I had the ability, I don't blame them. Do you know how many memos? It would be so nice to just real quick. I can't find it. It's somewhere in there. I know it is. Let me just, there we go. It's going to be hard to break I don't want to say disdain. I feel like that's a little bit extreme, but break the phraseology of, well, I don't know, but we can take you to the ER and they can do more things and they have a better pay grade than I do. I'm going to have to break that habit. It's going to be hard to just be like, I don't know, but let's go get checked out. Then they'll be able to figure it out. I will be part of the day doing the figuring out. That's terrifying.
But what's nice is that as a paramedic, like, for the most part, you got your partner right there. And then, I don't know how every system works. We had the fire department as well. But for the most part, the paramedic kind of took control of those kind of calls. And you didn't really have a backup. There's no 912. You were it, right? In the hospital, it's pretty easy. Like, if I have a patient coming in and, they're having some weird throat symptoms or whatever, I'll just call ENT, kind of give a breakdown what's going on. Hey, do you mind come doing a consult for me? Oh, patient's having some chest pain. Hey, cardiology. These are the important things I'm hitting on. What do you think? Do you want to come do a consult for me? That's why we have all these various specialties. In emergency medicine, we're supposed to be know a lot, but be a master of none and all that kind of stuff. Obviously, we have our own little niches where we all like, respiratory, cardiology. Yeah. We kind of gravitate to those areas. But, if you talk to me about OB, I'd be like, you said it with confidence, so I'm going to believe you, and like, like, I don't know a thing about OB or gyne or whatever. It's pretty out of my league. But I admit that, I try to learn it. It's not the most exciting thing for me, but I try. But at the end of the day, you always have those consults and people to ask. You have assistants and people you can always rely on. At least in the hospital setting, for the most part, you can reach out if you're floundering and you're like, I don't have a clue. You always have other PAs or other physicians or even really experienced nurses, especially if you're a brand new PA coming on. You're kind of going to look at them like, hey, so, what's kind of going on here? You don't want them to be like, oh, okay, that's what you want to do. Are you sure? Then you got to be like, oh, I mean, what do you think is going on here? Like, the experienced nurses, like, they've seen so much, especially in the specialty for so long. It's like, second nature to a lot of them. And at least you can get some kind of idea. It's like, oh, well, a lot of patients, we get a lipase on these patients or, and I was like, oh, okay, maybe that makes sense. Like, did you see
great idea?
You see the patient drank like, 2 liters of alcohol every day? And I'm like, no, I didn't. And they're having epigastric pain. I'm like, oh, yeah, but like, and they're like, I'd get a lipase. And I'll be like, Yes, ma'am. I can do that. You know?
If you insist. Oh my
Yeah.
God.
So you have a lot more support in the hospital system. And obviously, if you have a really good partner that you kind of just synergize with, it's really amazing to be able to bounce off ideas and stuff like that. But, having 500 specialty people at your disposal versus, just you and your partner and occasionally Google if you have a chance, there's there's, you have a lot more to lean back on.
Chest pain plus sweating plus 12 lead
Like,
equals.
what do I do? It's like, patient is having chest pain. What do I do? It's like, call 911. Crap. Okay.
Oh no, we're past that step.
What's the next step?
Sir, please wait. I'm trying to figure out where we're at right now. You're interrupting me.
I'm typing in the chat GPT. Give me a second.
You might have to put headphones on real quick. It helps me relax. How to start an IV.
How to start an IV. How to do chest compressions.
I'm a professional. Okay, so you are wrapping up on the PA program. You are about to finish all of the things, pass all your tests, do all of the great things. What's your next step from here?
So right now I'm applying to various jobs. If you were a betting person, you would probably assume cardiology, and I would say you're completely right. My goal is cardiology or critical care. If I could marry those two together and get into like the cardiovascular ICU or cardiac ICU, I'd be in heaven. That'd be the perfect job for me. I would love to do something like that. So that is my plan. I'm applying to the city that I live in now, and because I really like it here, it's beautiful. The wife wants to stay here, and my goal is if that, no jobs open up in the next couple months, then I'm going to just start expanding and start sending out my applications. But what I've kind of gathered from so far is that most places, like when you apply to them, you usually speak to a recruiter first, and they kind of just hype up whether it is like, are you willing to travel and stuff. My buddy, he's been traveling and stuff like that, and they'll do like site visits, and it's basically like, are you not a terrible person? Is usually the interview process. Like, it's like, you're smart enough. It's all contingent on as long as you pass your pants, get your boards and stuff like that. But then a lot of it is, just making sure that you're cool enough to kind of jive with the kind of people you're going to be with. And like when I did my critical care rotation, I had a really fun time, there. And in my recommendation letter I got from them, they said, he fits in really well. And I'm like, and I've had a couple of resources and sources tell me that that's what they ask on a lot of their kind of things. Like, they'll ask a couple like clinical, they're not going to like pimp you on like, it's like, what is the cause of, hydronephrosis or something. Like, they're not going to say stuff like that. Like, they're expecting you to come in with like very limited knowledge, and you're going to spend the next 6 months to a year, if you're in a really good place, getting mentored and learning about their systems and stuff like that. But I mean, they want to know that, can you learn and expand and adapt to things? And are you just a really nice, enjoyable person to be around 8 to 12 hours a day?
No, that's fair. And that makes a lot of sense because, like, I feel like it's such a different aspect from like EMS where you have your certifications versus the step above. So, like the hospital setting, PAs, especially doctors, things like that. You have all of the programs that are all the same. No paramedic program, when you look at it from this company or this education system, however you want to phrase it, you put that next to the one that's like the next county over, and they're two completely different things. But we also have the same national registry, however you get there, versus like these, I don't know, academic institutions that are all like, they have it together.
Pretty standardized.
Thank you. I am not standardized. So like,
I'm not either. You used some big words right there, and I had to think for about 2 seconds, and I'm like,
academia.
Institutions. That sounds fancy.
But no, like they see that you've done this school. Obviously, you've gotten here. They can look up your GPA, whatever it is. But now it's a matter of, we are all going to work as a team. We all have the same goals in mind, but also we are all different people. It's not like hey, are you not gonna, I don't know, ask for a different partner every week because you just can't get along with anybody? Versus, hey, how do you do well with other people under stress? Because I'm not that this is not me just like CYA. Like, seriously, I'm not going to yell at firefighters, but
No.
somebody else I work with might. I don't know. And it doesn't come back on me, it comes back on them, but they're not going to lose their job for it.
Yeah.
Versus it's a whole different ball game in the actual like hospital slash clinic setting. It's a very different. So it makes sense. It makes a lot of sense.
And a lot of it is patient satisfaction is kind, we obviously want to do a really good job and stuff like that, but I'm telling you, I talked to some PAs and stuff like that, and they're like, I some of their bonuses come from their overall grades and or scores from patients or patient satisfaction. They're like, I got like a 1-star Yelp review because someone couldn't find parking to get my clinic, and then that impacted a bonus, or I some aspect of that, and I'm like, that sounds terrible. So that's another big thing that's a little bit different. Obviously, you have a patient that complains to your supervisor, you're going to get a write up, maybe some learning or whatever. But I mean, it can affect how much money you make, and it can really. I mean, if I got a 1-star review, I'd be like, "What happened? Like, was I that terrible?" Like, imagine going and dropping a patient off, and then like, how you go and get a coffee, and they like turn around the stupid iPad, and they tell you to give them a tip and stuff like that. It's like, how was your experience on a 1 to 5 scale? Like, imagine doing that every time you dropped off a patient. You got enough ones on there, then you didn't get a promotion or something like that. Like, that'd be hard. I don't know if other systems do that, but I haven't heard of any.
I haven't, and I'm sure they don't. So, a lot of the things about a lot of things of what it means to go into physician assistant school, what it means to study to be in the physician assistant program, what even is a PA and why do they matter? How does it help us? If you could give somebody advice, somebody being me or somebody else that wants to be a PA from paramedic to PA, what is some key advice besides learn your labs? Key advice to like really help kind of narrow down, somebody that wants to do their next step. Because in this field, if you have your EMT, and no offense, especially if you have your paramedic, your next step, if you want to leave the EMS field, you have a lot of options for your next step possibilities. So anybody that's thinking about it, what would be your advice to help somebody either on the fence of, should I do this? Should I not? Should I stay in EMS? I don't know what to do. I don't know if I want to make mean salary of 100K a year, but to each their own, I guess.
My advice would be to kind of plan out your future. Just be like, are you content and happy with what you're doing? And can you still see yourself doing it for the next 30, 40 years until you retire? I don't know if you can hear this. There's a thunderstorm just came out of nowhere. Ooh. But regardless, sorry, Jacob.
Oh, that is a good. Oh my God, that's a good one.
Sorry, it just, yeah. I don't know what just happened. It just kind of came out. So anyways, so the number one advice I would kind of give is just to understand your trajectory and what you're happy with. Like, are you content with what you are making now? Do you feel comfortable now? Can you still see yourself doing this in the next 30, 40 years or something like that? If you're having a thought, or you don't know if you want to do nursing or PA or, go to MD school, go shadow, go do shadowing. Ask the physicians when you drop patients off, go find a PA, a nurse, or a physician, and ask as many people as you can what you think about it and how do you like the job, the work-life balance. Don't ask them salary. They're probably going to, tell you no. Google, dude. But ask about like work-life balance or important aspects of life that you find valuable. I like to have a good work-life balance and stuff like that. I don't want to be, as much as I love medicine, I don't want to be stuck at a desk, developing DVTs in my legs from sitting for so long, right? And I am also not a very active person. I don't walk very well. So, I'm not going to be, I try to find that little happy medium. So ask and do volunteering or shadowing these various providers to see what they do, what their day in life is, and try to see what you can learn from them. And that can kind of narrow it down a little bit for most people, I believe. So you want to kind of know before you are like, I'm going to go go back to school and get my bachelor degree in this and do all these classes. You go through school and you realize, oh God, I hate this. This is not at all what I want to do. Well, guess what? I'm sorry. You're on the train now. Like, you can jump off if you want. It's going to hurt though. So it's really important that you find exactly what you want to do the rest of your life. And that's at the end of the day, it's as much as I enjoy wanting to be a PA and going to PA school and stuff like that, that was the right decision in my aspect for me, but it might not be for someone else. And at the end of the day, the only one that can answer that question is you, the person, the viewer.
No, 100%. I don't know, and it's just it's the same thing as like when somebody wants to come into EMS and they're doing just like their third rider, just getting a feel for it. Having a crew that will be honest with you and say like, hey, like one time we had this third rider, sweet girl. Oh my gosh, still feel so bad. It was our 4th shift in a row to get a code, and the person come back, which is awesome. Love that. My God. Like I got into shift an hour early to finish up the paperwork from the one yesterday on top of all the other calls. Mama was burnt. I was so burnt out. So like we had this sweet girl, she's coming to her ride times, and we're just getting slammed with one thing after the other. And it got to the point where we're on the way to the next call. I said, hey, it was the cardiac arrest. I said, have you ever seen a dead body? She's like, no, ma'am. I said, well, buckle up, kiddo. We're going.
It's like, I'm going to apologize in advance how I'm going to react today, but I'm not burnt out. I'm feeling a little crispy today.
No, I was flip me over, call me well done. And I apologized after, but like it was very helpful for me when I started EMT school and stuff. Having someone say like, hey, you learn about these things because we can do these things. We can do these really cool things and like save somebody's life, this, that, and the other. But that it happens kind of mostly very rarely. So like you have to be okay with, you may never see this, you may never see that. You may have 3 months span of time of just the most BS, ridiculous calls, but you have to always be ready for that one.
Yep.
And that still to this day, like I go into my shift, and if it's like, especially right now, I'm back on 24s. So if it's 6 a.m. and I get off at 7 and I know it's been pretty cake, I start sweating that last hour because it's like, oh God, what's next?
What are your rest going to come out? The GSW, the penetrating trauma. All that large narrative I'm going to have to type up and all those boxes I got to click.
When I was in paramedic school, one of the medics that I know, he had been doing it for so long. And I asked him, I said, at this point, like you've seen a lot, you've done a lot, you have the awards, whatever. I said, what's the worst part? Like, just be so for real. And he looked at me and said, the paperwork. He said, if I could do this job without the paperwork, I would do it for free. And I was like, oh my God, it's not even that bad. Be so for real. It's that bad. It's disgusting.
It doesn't get better. It doesn't get better in school. It is. I'll send you some of my notes after the show, like my type ups and stuff like that. They are fun. But if you go to MD school, you can take a lower salary and have a scribe type up your notes. I'm not going to do that. But
I was about to say I'm not going to sacrifice any of my pay cut. But
no, not at all.
If I had doctor's salary, okay.
Yeah, I'm like, I'm $250,000 in debt. You think I'm going to give up any of my pay? My children will be in debt.
You can have the firstborn. I'll keep the other ones.
Yeah.
Here's my scribe.
My kid watches this one day. Just remember, please don't put me in a home. You will get the debt.
I mean, if it has anything to do with like your benefits and stuff, you'll be fine.
Yeah. But there are some places that do pay it back, like the VA and stuff like that, but they are on a hiring freeze. So
I have a lot of thoughts about the VA. Yeah. Well, very good. Man, I know, and like if you're listening, if you're watching, you don't understand, but Matt was very gracious to send just little blurbs and lots of study guides and stuff. And when I say it is so much, it is so much. Already had mad respect to the PA field, hence why like it is an option at all. If I didn't respect it, why would I do it? Mad respect. But now, it's a lot. A lot of info. Woo.
You and caffeine will
But
become best friends.
we already are. Oh no, it's so toxic. But lots of good info. If you have any questions, hit me up. Hit up Matt. Matt has a lot of questions. Yeah, obviously at this point, especially has a lot of knowledge, a lot of experience. And if you have any input, insight, anything like that, drop a comment below. I don't know, whatever all the cool kids say about finding them on social media. I don't know. I just exist. So, Matt, if you want to add in anything else, I covered everything I got. Do you have anything else?
No, that's it. Thank you so much for having me on the show. I had a blast.
Oh yeah, it's always a good time. And who knows, maybe in 5 years when I eventually get into PA school, I'll have you back on and we can do a little riff-raff of like, oh, this is what I've learned. Oh, look how cool we are. Ha ha
Yeah.
ha.
I mean,
And
you can't be too old. We have people in my school who are in their 50s going to PA school, and 40s and 30. I mean, I'm 29,
I was
but
about to say what she was trying to say, that 30s is old, because you better watch your tongue, big guy. That hurts my feelings.
no, I feel old. I have to take ibuprofen every day to get out of bed. My joints.
I stopped plucking the gray hairs I find in the little like crevices at the back of my head. I've
Yeah.
stopped plucking them because what's the point?
I'm gonna
They're
go
coming
bald
back.
if I keep plucking them out. They're all right here. I'm getting them here, and I'm like, every time my wife's like, I found another one, and I'm like, yeah, you stress me out. She doesn't like that, but I get a little giggle out of it, and then I sleep on the couch, but it's okay. It's worth it.
What's one night to have a laugh with friends?
Exactly. What's life if you can't smile and laugh and joke around and stuff like that? Life's too serious. Have fun. Piss someone off today. You can cut that, Jacob.
Don't cut it. No, we'll cut that. All right. Well, Matt, almost doctor, but not quite doctor. Matt.
No. I will not fulfill the destiny of associates, bachelor, master's, and doctorate after this, but I feel confident being in school for like 8 to 10 years at this point.
Oh.
I'm happy.
You have a paper or two to show for it. But
Yeah.
if that is all you got, I appreciate you coming on, man. I appreciate the in advance hand holding we will do together as I cry and call you and ask you, oh God, what am I doing wrong? But
I'm always available.
So as we close out every episode, if that's all you got, that's all I got.
The 22 at the Lips podcast is designed to support, not replace, the relationship that exists between a practitioner and his or her medical director. The views and opinions expressed in this podcast are those of the host, guest, and not necessarily of Master Medics. The information provided during this podcast is intended for educational and informational purposes only. It is not a substitute for your approved protocols.